Hey everybody, how's it going today? Just gonna wait for a few minutes. I'm about 2 minutes early. I need to shut the sound off on. I don't need to hear myself. Hey, Boone Lobotomized, how's it going? Hey, Music Juice, happy Friday. Yeah, that's where I want to go. Nope, I lied. Follow you on Beauty Sky. Nice to finally catch a stream. Yeah, like it's just kind of like the slow thing. I was, a piece of me really, really wanted this idea that I was just gonna grab all my followers from Blue Sky and grab all my followers from Twitter and get them all to come over here to my Patreon and to my Twitch account. And I think that was just lofty and kind of a wish. Um, at some point, you might see some ears pop up over here. My little Shiba has decided to join me on the couch, so he may or may not decide to show up. Yeah, I plan on giving it a little bit of time. Um, I am still learning ish how to operate my screen here on my phone and on this at the same time because I can't monitor this and do a slideshow at the same time because it shows up as a very long tunnel of screenception. Anyway, I'm going to be doing some antibiotics today. I thought about doing some much larger, a much larger one, and then I realized that in trying to do that, I was going to end up having a stream that was like 5 or 6 hours long just to get through all of it. So I'm going to break these down into blocks. And so one of the things I'm going to also note is that if you've been through med school or you've been through nursing where they go a little bit more in depth on antibiotics, there are some things that I don't have in there, mostly because um, this is very basic. It's not going to include like what it treats. So I'm not going to talk about like Klebsiella. I'm not going to talk about strep pneumonia or I'm sorry, like yeah, strep pneumonia, Staph aureus, strep pyogenes. I'm not going to talk about how these treat those because I think in order to do that, I'd have to go through a microbio uh, stream first in order to do that. So what I'm going to do is I'm going to do this first. I'll probably do a microbiome stream in the future, and then I'll bring them back together and do kind of like what we do some of our lectures for med school is we do these two things kind of separately, but in the same kind of time frame, and then we just kind of merge them together and start talking about how you would treat things like strep pyogenes or uh, mycobacteria, mycobacteria tuberculosis, um, fungal infections, yeast infections. Um, by the way, if you're immune compromised, be careful when you're making bread because you can get a yeast infection from the yeast that you use. Not saying anyone specific. Um, how was my first year? I just finished my first semester. I didn't have to remediate anything all semester. I passed everything. I think I have for one section because we're broken off into two sections. So we have your clinical side, and then we have our medical knowledge or our science side, which is like your classroom stuff. So I have like in my clinical side, I think like an 82, and I think for my medical knowledge side, I have like an 84 or an 85 average. So I'm passing. And to be honest, like uh, out in the world, you get a lot of professors that will say things like, "Oh yeah, C's get degrees." I'm not really a big fan of that phrase in undergrad. At your associate's degree level, at your bachelor's degree level, I don't like that phrase so much because if all you're doing is just going for the associates and you're never going to want to go anywhere else, yeah, sure, a C is fine. If you have an idea that you might want to do more than that, you might you might want to move on to a master's degree or an advanced degree or a terminal doctorate or a postdoc. I would not go for the C. I would go for something more B pluses, A minuses, somewhere in that ballpark. That'll do you much better. But if all you care about is just getting your ADN so you can get that RN and just go to town on being a nurse forever, or go do whatever it is you're going to do with that associate's degree, sure. As for the doctorate side, I don't need to burn myself out trying to get 100 anymore. Nobody's going to care if I have an A. The big thing I need to do is I just need to do well on my clinical side, which is in year 3 and 4, and then my residency. Um, yep, pass equals MD, or in my case, DO. But yeah, so I don't like the idea of just burning like that. I had a 4.0 in my undergrad. It was not worth it. I finished at like 2 something in the morning in August of 2022, I think, 2022, and everyone asked me how I felt about it, and I said I felt nothing. I was so numb. I was so burned out. So a 4.0 in my doctorate, not really worth it, and so I don't really care. Anyway, let me see if I can see on view. There we go. Okay, I don't need that. There we go. Now I can see. All right, so I've got we're about 7 minutes in. I've got four viewers going. This is going to be passed on. This is going to be downloaded and passed on to my YouTube channel. You can find me again at Random Street Medic on YouTube, Random Street Medic on Twitch, Random Street Medic on Patreon, Random Street Medic on Twitter, and on Blue Sky. Anytime you see Random Street Medic, it's this space. It's me. So, all right, we're going to get into some pharmacology. Specifically, we're going to be talking about some antibiotics. So to start with, what is an antibiotic? An antibiotic is a medication or a chemotherapy that specifically targets foreign invaders of your body, specifically bacteria. And I say chemotherapeutic because it's in a basically large umbrella of um, medication types. And for the most part, most medications are some variation of chemotherapy. And when people hear chemotherapy, they think cancer. Um, that is a form of chemotherapy. That is just a localism, not local, but it's just a general colloquialism for cancer therapy. But chemotherapy just has to do with the large branch of trying to treat things with pharmaceuticals, which are chemicals. So hence chemotherapy. So in general, what is the trajectory for antibiotic administration, like empiric or broad treatment versus definitive and narrow? So when I say trajectory, so when you go to your doctors or your hospital, you generally don't walk in and just immediately get you don't just immediately get sorry, trying to do this on my phone at the same time, an antibiotic. What generally happens is you go to the doctors or you go to the hospital with a specific set of symptoms. Um, And so the trajectory is you go to the hospital, you go to the doctors, you have a specific set of symptoms. Usually it's something like you've got fever and other signs that you have an infection. So if you're at the hospital, generally what we're going to do is we want to administer a few tests, like a CBC, which is a complete blood count, and we're going to look at your white blood cells. We may look at the differential, which differentiates between things like your lymphocytes, your monocytes, your neutrophils, and we want to see, is there an infection? Is there not an infection? And generally, some of these tests will walk in that direction. And so a couple of the other tests are things like culture and sensitivities and susceptibilities. And all that's doing is if it's going to grow something, it's going to tell us what's growing. It's going to tell us what antibiotics will work. And that's through the sensitivity and susceptibility tests. Um, when you start with an antibiotic treatment, especially if somebody is coming to us in the hospital, we tend to start very broad, which is your empiric. So you're just going off of what kind of infection. So is it a respiratory infection? Is it a urinary tract infection? Is it a skin infection? So you start there, and you're kind of going with what's most common in the area. So you start with a broad treatment. So you take a broad spectrum antibiotic, and then you start there. And then when you get your cultures back, then you go into the more definitive and go more narrow. So the general rule is as soon as you know what you're dealing with, you go to a more narrow treatment as opposed to something that, hey, we're going to treat both gram negative and gram positive and everything all over the place with this one antibiotic, which, by the way, it's not one antibiotic. Nothing covers everything. There are medications that are kind of more broad spectrum. There's some that are a little bit narrower, but then you transition over into more definitive care, which is a targeted antibiotic, which goes after a specific organism. And that's going to be on either an antibiogram, which is like a printout. It tells you what each thing is susceptible to and by how much. Or you're going to get a readout on any number of your, resources that say, okay, this is the organism that this person is infected with, and this is the medication that it is susceptible to. So this is what you should use. So when we talk about gram staining, capital G, gram stain, it is named after a person. That's why it's a capital G. So what a gram stain does is, and there's a bunch of different stains. There's acid fast. There's silver staining. But in general, most hospitals and most places, unless you have a very serious illness, which is on the more rare side, they use something called gram staining. What gram staining does is it dyes the outside of a bacteria either purple or a very light pink. If it's purple, it's gram positive, and I'll show you why in a moment. If it's purple, it's gram positive. If it's light pink, it's gram negative, because it just means that it's not holding onto that dye in the same way that it would if it's dark purple. And that's kind of how you differentiate between gram positive and gram negative. And what that basically tells you is what the outside of the bacteria looks like in terms of its cell wall and its external structure. So what kind of patient consideration exists for antibiotic administrations? Allergies. Big one is allergies. So when you hear someone say, I have a penicillin allergy, one of the things you kind of want to ask is, what happens when you take this medication? Because a lot of people will say, I have a penicillin allergy, and they either haven't had penicillin since they were 10 years old, and they're 40 right now, and they don't actually know what happened, or they had a very slight rash, or they had some GI symptoms or some gastrointestinal symptoms like some nausea, maybe some diarrhea, and those aren't really true allergies. A rash can sort of kind of walk in that direction as a more true allergy, but what we're looking for is things like anaphylaxis, hives, anything that is a life-threatening, Steven Johnson syndrome, anything that's really life-threatening. Those are hypersensitivity reactions. Those are the ones that we want to look out for. Also, we want to look out for things like, is a patient on dialysis? Are they in kidney failure? Do they have a liver disease? Anything? Do they have a pre-existing issue with their ears due to another medication? So you're going to hear the term ototoxicity, and certain medications will make that worse, and you have to know these things. So you want to make sure that you have a big, broad look at your patient, which includes allergies, medications that they already take, pre-existing conditions, be it kidney, liver, whether or not they have neuro conditions, because there are medications out there which will interact with antibiotics and make neuro symptoms worse. What's the difference between bacteriostatic and bactericidal? We're not going to get into that like in that kind of depth in the following slides, but in the broadest sense, bacteriostatic, anytime something is static, it stops its moving. So you're basically making sure that bacteria aren't proliferating. You're just stopping them where they are, which allows the body's immune system to attack them more efficiently, or they just eventually die off over time because bacteria have a lifespan. And if they're not able to eat, they're not able to move, they're not able to reproduce, they just kind of sit there and eventually die off. Or as I said, they get attacked by the immune system and die off that way as well. Bactericidal, uh, bactericidal antibiotics or medications directly kill bacteria. So either by disrupting their internal metabolism, disrupting their protein synthesis, or punching holes in their wall, causing water and other things to leak in, their internal components to go out, and they just kind of burst and go away. Let me not go away, but they kind of burst, end up dying there. The unfortunate thing about bacteria bursting is a lot of things that they contain within themselves are not good for us. So that tends to make us very sick. So we kind of hope that our cells kind of go, our immune systems kind of jump on that really quickly and eat them before they release their contents. But unfortunately, that doesn't always happen. So sometimes when you see people are very sick, it can either be because a large amount of bacteria have died and their contents have spilled out, or it's just a kind of bacteria and their outer capsule can make people very sick on their own. So when is it appropriate to use antibiotics? It is appropriate to use antibiotics when you have a bacteria. It's not appropriate to use antibiotics when you have a virus, unless you're specifically trying to prevent a secondary infection down the road, which tend to happen sometimes, especially with upper respiratory and lower respiratory infections. You can get a virus first, 10 to 15 days later, you end up with the bacteria that kind of sweeps in because there's tissues that's damaged, they can get a foothold. So it's appropriate to use antibiotics in a person that, you know, they're ill, they're showing all the acute signs and symptoms of an illness related to a bacterial infection, whether it be cellulitis or a skin infection, whether it be a pneumonia of some kind that when you look at X-ray imaging, it says yes, that's most likely bacterial, and especially when you start doing testing. So the big thing is you want to make sure that you're doing your testing, especially getting your cultures, and you're attacking the correct organism. You don't want to be treating viral illnesses with bacteria with antibiotics, because that's how you end up with antibiotic resistance. That gets us kind of onto what is antibiotic stewardship, which kind of encompasses all the things that I just talked about. Uh, if you went back about 10, like maybe 10, 20 years, you ended up with um, people who uh, would just hand out antibiotics very easily and without really doing any of the testing. They would just go, oh, you're not feeling well, here's an antibiotic. And what we found is that when you do that, you increase the rate of resistance in a community by doing that, and it nullifies the effect of the antibiotics. So stewardship is making sure you're protecting the integrity of the antibiotics that are being used in an area. And also you do this by things like you're using multiple antibiotics at the same time or combination therapies, not just a monotherapy or a single antibiotic. So that way you're overcoming resistance, you're making it less likely that bacteria are going to become resistant. And it's just, it's kind of our job as healthcare providers, be it as a physician or a nurse, to make sure patients are um, aware of why we may or may not why we may or may not prescribe an antibiotic. And it's mostly for their benefit, so that way they're not going to end up with a super infection or a multi-drug resistant infection that is more difficult to treat later on down the line. So what is antibiotic resistance? What mechanisms do bacteria use? Antibiotic resistance is pretty much what it says. It's resisting a medication that you're giving to kill off the bacteria or make it stop proliferating. And it does this by a bunch of different ways. And I'm saying that as if it's consciously doing it. It's not so much a conscious thing. It's just part of the process of different organisms. So they can pass on resistance to one another. It's called horizontal. It's called horizontal transfers. So bacteria can pass on uh, bacterial genetics to one another. Sorry, the bacteria can pass on genetics to one another. So, say that one gene allows for it to um, degrade an antibiotic that's being used and makes it less effective. Well, that bacteria is going to live long enough to reproduce, and it will reproduce that gene because the other bacteria around it will get killed off that don't have that gene. So now you have a resistant bacteria. It can do this. Another mechanism is by it can have a mutation that changes the receptor for that specific antibiotic. It can have a mutation in its cell wall that allows it to pump out antibiotics. So the antibiotic will go in and then it'll immediately get pumped right back out. They're called efflux pumps. So there's like about a half dozen different ways that that a bacteria can grow resistance to an antibiotic. Is this going to be a lecture or like some response? Mostly it's going to be a lecture, but I'm monitoring the chat here so I can peek in to make sure that anybody has any questions. I can answer those questions. Actually, I'm going to take a quick pause because I want to. Um, I did not share my stream in the. Did not share my stream in to my Twitter, which was bad of me. So you can ask questions if you'd like. I just have to do this real quick because I did a bad and I forgot to promote myself. So yeah, ask a question. Well, I just jumped off my screen. One moment. I promise him. I promise I'm not an old. I mean, that's not true. I am an old. I feel like I'm old right now. I know someone's going to comment from my class at some point and be like, you screwed up, bro. That's gonna have to be good enough. All right, and I'm back. Womp womp. That's my fault. Just want to make sure I'm not missing stuff while I'm playing. No, no, not at all. As I said, the I'm open to taking questions from anybody. They just gotta pop it into the chat as we're going, and I'm as I said, monitoring the chat over here while I'm also trying to do my slideshow. But yeah, so basically antibiotic resistance, as I said, is how bacteria stop antibiotics from working either by changing the target that the antibiotic's going after on either a cell membrane or on the inside. They can have pumps on the outside of their cell walls and membranes, which basically your antibiotic's going to go right in the cell and will immediately go right back out. They can also create enzymes which chew up your antibiotic and make them less effective, or can actually just make them completely useless. Especially in things like penicillin, where you have something called beta lactamases, which is what we're going to talk about in just a moment. So when we talk about cell walls, we talk about gram staining. So I just say gram capital G is named after a person. It's not like just a test itself. It's named after a person who came up with staining. And what it does is it has to do with whether or not it gets stuck in a cell wall on the outside of a bacteria. You don't need, unless you're in medical school, you don't really need to know everything that's on the screen, but this just kind of give you an image of what bacterial cell walls look like. On the gram-positive side, you have something called this big, thick layer on the outside, or multiple layers on the outside called peptidoglycan. It's basically what traps gram staining. So when you go to wash it away, you usually use like an ethanol wash. That stain will stick in that space. On the gram-negative side, you'll see how the peptidoglycan is covered by an outer membrane. And it's covered by we call it LPS. It's a lipopolysaccharide layer. LPS for gram-negative also is generally what causes the most antigenic toxicity. So it makes you really sick when you're in contact with the outer membrane of that specific kind of bacteria. But so gram staining on the right side, where it's gram negative, isn't going to stick around because it can't penetrate all the way down to where that peptidoglycan layer is. Where on the other side, on the left side, you have gram positive. It's going to get all trapped up in those layers of peptidoglycan. So when you go to do gram staining, what you're going to see in the microscope is you're going to see a very dark purple for gram positive and a very light pink, or like a reddish pink, for gram negative. And it helps differentiate between different kinds of bacteria. Hey, I'd fight for them. How you doing? How's Vegas going? So this is how gram staining works for the most part. It just helps you differentiate between different types of bacteria, especially with bacteria that looks very similar. Dusty, especially different types of bacteria that look very similar, because you can have, they're called cocci. They're like little balls. You can have ones that are diplococci, which are two of them stuck together, and they can either be purple or pink, and they're two very different bacteria, and they respond to two very different medications. So it helps you learn what you're dealing with when you're looking at, basically by culturing them and then gram staining them. And as I said, there's a bunch of different kinds of staining out there. There's acid, fast, and silver staining. You don't need to know that for what we're doing here. So the first type of medication, oh, it didn't save. Oh, all right. So the first type of medications that we're going to talk about are cell wall inhibitors. This is why I put the cell walls up here. Cell wall inhibitors, the whole point of them is to disrupt the cell wall for bacteria. It's pretty self-explanatory. And it'll do this by, for the most part, stopping the bacteria from being able to continuously create these molecular linkages that create their cell walls. And it'll eventually create pores, which the external environment will rush in, internal environment will come out, and the cells will end up dying. As you can see on top of the screen here. It talks about the antibiotic-free cell wall synthesis, and this is just kind of a picture of that peptidoglycan, which uses a penicillin binding protein, which is why it's called penicillin. And that little thing that's in the circle is called the transpeptidase subunit. It's basically an enzyme that links these little molecules together. The main beta-lactam medications that we use to go after a cell wall in bacteria are things like penicillins, ampicillin, all of those, anything that ends in the cillin, same family. And they're called beta-lactams, not that you really need to know this because it has a little square molecular shape, and that little square is called a lactam. But all these medications, penicillin, cephalosporin, so things like ceftriaxone, cefazolin, you have carbapenems, monobactams. So those three up there, penicillins, cephalosporins, and carbapenems, if you're allergic to penicillins, there's a chance that you're going to be allergic to cephalosporins and carbapenems. So you want to be aware of that. So if you do have a penicillin allergy, you want to make sure that it's either a true allergy. If it's a true allergy, you want to make sure you're aware of that. If it's not a true allergy, you don't want to eliminate your ability to use cephalosporins, just because it's the next step. It's kind of like the next step in the line of antibiotics in terms of trying to attack an organism. And if you remove it, you have to go to other ones which are a little bit less friendly for your stomach and for other parts of you. But the main beta-lactam used for cell wall inhibitors, penicillins, cephalosporins. And what they do is they inhibit that little enzyme up there that I mentioned. I'm just going to use the mouse right here. This right here, transpeptidase. And what it does is it kind of just jumps in here and makes it so that they can't link these molecules together. And since they can't link these together, the cell wall eventually breaks apart and it allows everything that's outside to rush in, everything that's inside to rush out. And they hopefully get gobbled up by macrophages before you get sick. But that's generally how these work. To resist this, these bacteria can release something called beta-lactamase. Beta-lactamase pretty much inhibits your penicillins and your cephalosporins. So what you have to do is you have to give something called a beta-lactamase inhibitor. So that's when you start getting like your augmentins, which is penicillin and a like clavonic acid, which inhibits the beta-lactamase from going after the penicillin, and it allows the penicillin to go into the cell and break down that cell and break down the cell membrane. Sorry, the cell wall. Another thing that the bacteria can do is, again, target modification. So it can change the availability of or access to that binding site, so that way penicillin doesn't bind as easily, either through just changing, like it'll mutate. And when I say it, I don't mean like one cell, I just mean through a generation. So several generations down the line, it can mutate at that one cell where the penicillin binds, and it becomes less effective over time. So to overcome that, again, we use beta-lactamase inhibitors, like again, changing from just penicillin to like an augmentin, or we just select a different medication which goes after a different target. Brings up something like vancomycin. Vancomycin is generally used for things like MRSA infections and VRE, so a little bit more resistant infections. And as you can see, so I'm going to change back to the screen for such a second. When you go to the next screen, you're going to see on the right, you're going to see something that says glycopeptide. And what these do is these bind directly onto the end caps of each of these molecules, and we call it the diala-diala. So these don't directly block transpeptidase or transglycolase, but what they do, because they don't jump on those enzymes themselves. What they do is they end up on the ends of these molecules so that they can't interact. So transpeptidase can't link those ends together, and transglycolase can't do that either. So The resistance, of course, for this is there's a modification for DLL, and it turns into DLL-D-lactate. And when it does that, um, vancomycin can't attach to that spot anymore, and um, it's able to avoid vancomycin binding and destroying the cell wall in that way. Similarly, actually not similarly, another resistance I didn't put on here is gram-negative bacteria. If you remember, if we go all the way back, so you'll notice that the peptidoglycan is on the inside of that outer membrane. Because of this, medications like vancomycin can't actually get into that space, so they are resisted by gram-negative bacteria just structurally. So they have a hard time getting down to that layer. Whereas with the gram-positive wall, the gram-positive wall is just right on the outside, so it's easier to interact with it. One adverse event, and they changed the name for good reason. One adverse event that we always keep an eye on is when you give something like vancomycin, you can get what's called a vancomycin infusion reaction. And it looks exactly like anaphylaxis. It looks like it would be like a type 1 hypersensitivity reaction. It's not. It's a histamine response caused by your vancomycin being infused too fast. Generally, when you give vancomycin, it's infused over like 90 minutes, depending on the dosage of it. If you push too fast, they get very flushed in the face. They can get significant swelling in the mouth and the airways. They'll start tearing. They're going to start drooling all over the place. They'll have a difficult time breathing. They're wheezing. And again, it's exclusively to the overwhelmingly large histamine response. If you stop the medication, it goes away pretty quickly. Generally, when that happens, we do that, give Benadryl or another antihistamine by IV, along with something like Pepsin. And either we restart it at a slower rate or we just switch to another antibiotic. But generally, that's not due to an actual allergic reaction. It's due to you giving that medication too fast. Which brings us to a nursing note. Always make sure that you're reading the route of administration and the speed of administration. Don't just slam people with medications, especially meds that do stuff like this. Same thing with medications like Haldol or Benadryl, or especially Compazine for things like, if you're a nurse out there and you get an order for Compazine because the patient's really nauseous or they have a migraine, if you push Compazine too fast, they get a dystonic reaction and they get akathisia and they start bouncing off the walls, and that's your fault. So it's not the patient's fault. It's nothing they did. You gave that medication way too fast. So always make sure that you're giving medications in the correct route at the correct rate. Don't just, slam meds on people. Even morphine, and people do that all the time. You get two sets of nurses. The one set will slam morphine really fast and makes your patients really sick because it can has a histamine response. And the second set is changing the entire dose of the medication by putting it in like a 100 ml bag, which dilutes it all the way down to uselessness, and they're not actually getting any pain medication or pain relief from it. So make sure that you're giving meds the way they're supposed to be given. How long was I a nurse? I started nursing at the end of 2020, so I was the original OG graduating class for the pandemic, and I was a nurse all the way up until April of this year. Yeah, I think it was like April or May of this year, so about 5 years almost. Other things, and this goes back to what I said about making sure that you are taking your patient's considerations in mind. Patients can have kidney injuries and ear injuries if you give this medication at a very high concentration too fast. So when you see nephrotoxicity and ototoxicity, oto is ear, nephro is kidney. So if you give it at a really high concentration, again, make sure that's at the right dose and at the right speed. Don't be giving people this huge dose of vancomycin because you can actually really hurt them in several ways. And then everyone's favorite first aid medication, you have some bacitracin. Bacitracin, I just put this out here, it inhibits by basically this dephosphorylation of bactophenol, so bactophenol biphosphate. It, instead of targeting a protein or a peptide, it actually targets a lipid. And it does this by taking, that's why you see bacitration, it'll be like zinc in it. It takes zinc and shoves a zinc into the critical structures of the cell walls, and it stops the transfer of the peptidoglycan units, and it causes the cell wall to break down. It is only for topical use. If you give this systemically by IV, you're going to make somebody very, very, very sick. Yeah, so you can give vancomycin orally, and it is used. It is one of the very few oral usages for vancomycin is for C. diff. And we actually talk about that in the future. C. diff is gross, and you want to make sure that you're not accidentally causing your patients to get C. diff. For those who don't know, Clostridium difficile is a naturally occurring bacteria in our GI, and it will blossom if you kill off the other gut biome that keeps that in check, and it causes ulceration, it causes severe diarrhea. It's not a good time. And it is very, 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 very contagious and very hard to get rid of because it lives in spores. But yeah, so bacitration, use that for, everyone loves the stuff in their first aid kits. It's used for skin wounds. We use it preventatively when we do sutures or any small kind of surgical procedure where I have to do, like, if I have to do like an incision and drainage and I have to lance an area, we're going to use bacitration on the outside of that just to make sure that that area is covered and that you don't get anything that comes in that's not supposed to be there. Again, topically only. Topical means it's on your skin. Don't administer this by IV. I don't even think there is one. But if you see a vial that says bacitration, don't put it in an IV. It'll cause kidney damage, among other things. And that really covers it for cell wall inhibitors. So again, cell wall inhibitor is exactly what it says. It inhibits the growth and the repair of the cell wall. And it's kind of big on the repair side because if you think about the way organic structures work, it doesn't create something and it stays that way forever. It gets damaged for one reason or another, either by pH changes, electrical changes, physical damage from a passing by antibody, or a passing by white blood cell that just nicks it on the way by in an attempt to eat it. So you have all these mechanisms that cells use to repair their cell membranes and repair their cell walls. And cell wall synthesis inhibitors will stop that. So that instead of being able to repair itself, it'll just stop, and you get these big gaps and sometimes these pores that will just be inserted into the cell wall and cell membranes, and the bacteria will end up dying, getting engulfed, hopefully, by macrophages. So that's cell wall inhibitors. And the next one that we're going to go into is protein synthesis inhibitors. So a little bit of background about protein synthesis. Bacteria have their own mechanisms to do this. Unlike viruses, viruses have to use your mechanics. Bacteria bring their own with them. And what they do is they create their own proteins, which do everything for them. And it's the same thing with people and human beings and every life form. Protein synthesis is the mainstay of every living object on Earth, with exception of viruses. And I'm not going to debate whether or not viruses are alive or not, but you need proteins, and your body needs to be able to make proteins in order to do everything. Whether it be repairing something, replicating, dealing with metabolism, protecting itself from other organisms. Everything that you do has to do with your body creating, storing, and using proteins. Sorry, I'm losing my voice as I'm doing this. So on the right-hand side of your screen, you see a ribosome, and that's where proteins are made in most cells. And each ribosome has subunits. So for human beings, we do not have the same subunits as bacteria, which is how we use antibiotics, is because we want to make antibiotics that attack bacteria ribosomes and not our own. So the bacteria that we go after tend to have 50S subunit and a 30S subunit. Sometimes they have a 23 subunit. You don't have to memorize this stuff again, unless you're in med school doing the microbiome stuff, then it becomes a little more important. But the point of protein synthesis inhibitors is it inhibits or interferes with the bacteria's ability to use its mRNA and transfer RNA effectively, which inhibits the bacteria from being able to make proteins, which are involved again in its replication, the repair of different parts of it, and also its ability to metabolize and use basically the things around it for food. What mRNA is, mRNA, as you see, is that nice little strand on the bottom there, and it's the template that is used as a messenger to create a protein strand. tRNA is the transfer RNA, so all those little green things that are floating around, those are tRNAs holding on to an amino acid that has a little ball on top. And what they do is they, as those things click in on the mRNA, the ribosome will put them together, hold them really close together, and those little peptide, those little singular peptide pieces on the very top will get transferred and bound together, and it creates what's called a polypeptide, which ends up becoming a protein. As a clinical note, macrolides and lincosamides, also known as clindamycin, they have a very similar mechanism. They work in the same place, and because of that, when bacteria are resistant to one, they are generally also resistant to the other in varying degrees. So if you have somebody that's sick and they have a resistance to clindamycin, they'll probably also have resistances to macrolides and azolides. So we're going to talk about lincosamides first. And the most common lincosamide that you're going to come across is something like clindamycin. So what I'm not doing is I'm not talking about the things that they treat, because again, in order to do that, I would have to go through a lot of microbiology, and that's going to be a separate stream at some point. But yeah, so lincosamides, they bind to that 50S subunit, that's the big one on top, and it blocks peptide bond formation and the ability of the ribosome to continue to add amino acids to the chain. And what it'll do is it'll kind of just block that whole area, and it becomes jammed. So because it becomes jammed, it can't add any more peptides to that strand, and it just stops right there, and it terminates early. So you'll get like a very small fragment. They're called nascent fragments. You get a very small nascent fragment of like maybe six peptides, and then it'll just stop because it can't keep going. It's not going to release anything, and even if it did, that protein is so small that it doesn't read correctly and it doesn't do what it's supposed to do. So the purpose of lincosamide is that its most common medication is clindamycin. It is an alternative. So remember we talked about penicillin and cephalosporin allergies. It's an alternative to an allergy to beta-lactams. And as we mentioned earlier with C. diff, this is one of those medications where when you take it orally, it can cause C. diff. And C. diff is very difficult to treat. Generally, you have to treat it with something like oral vancomycin or any number of other MRSA or kind of rough meds. I'll be honest, vancomycin orally is not a great medication. It doesn't feel good, but it is better than the alternative, which is C. diff. C. diff can really, really hurt somebody. It's very difficult to treat. It's also very contagious. And when I say it's difficult to treat, I also mean clean up, because it doesn't just get cleaned by bleach. Bleach has to be on there at a specific concentration for a specific amount of time, and they have to go in and really do a whole, it's called the terminal clean. And this stuff lives in spores, and it can get on anything and everything and survive for quite a while. So when you get patients that end up with C. diff infections, they have to be isolated. They have to have their own room. They can't share things. Stuff that comes out of the room has to go to special cleaning. So it's a whole thing. So this is what I mean by antibiotic stewardship. You want to make sure that you're giving somebody the right medication and that you're monitoring them for adverse events such as things like C. diff. The next one that we have up are macrolides and azolides. Macrolides, by the way, they're called macrolides because on the molecule itself it has this giant ring to it. Just a little knowledge out there, and that binds to the same place, roughly in the same place as clindamycin does. It blocks again that 50S subunit, blocks that exit pathway. It basically stops peptide chain elongation and protein synthesis. So again, it'll get like 5 or 6 pieces in. It'll hit the end of it, and then that bacteria will be like, or that ribosome will be like, oh, I can't go any further. So it'll be a protein that doesn't code for anything, and so that the cell won't be able to repair itself. It won't be able to metabolize things correctly, and it won't be able to replicate. if you get to it in time. A lot of times you'll see macrolides and azolides being used for respiratory tract infections, either upper and lower. Specifically, the most common one that a lot of you know of is Z-Pak or azithromycin. Um, I am not a fan of the way azithromycin gets used because I find that get people get administered a Z-Pak regardless of what their symptoms are, whether or not it's viral or bacterial, and that to me is not great stewardship. But that is just my opinion. But they are generally used for things like respiratory infections, either upper or lower, so like pneumonias or pharyngitis, like certain kinds of pharyngitis. Sometimes ear infections, but that has to be very specific. And lastly, I think this is the last slide, you have tetracyclines. Tetracyclines are named that way because they have 4 rings attached to them, 4 cyclic rings. And this is a different medication. So this one doesn't have the same, it works in a different area. So it doesn't have the same kind of resistances to that you would find for macrolides and clindamycin. So it's less likely to have a cross resistance. It binds to the 30S subunit. So instead of being up here, binds to the bottom. And what this does is it interferes with the amino acyl tRNA. So those green little spaceship-looking things that are floating around there, it blocks those from being able to transfer new amino acids, and it inhibits the chain from continuing to be made. The most common medication that you're going to hear out and about are things like doxycycline. Doxycycline is one of those antibiotics that gets used for, it's kind of like chicken soup almost. I see it administered for everything under the sun. But specifically, you're going to see doxycycline prescribed for things like Lyme disease, rickettsia, which is Rocky Mountain spotty fever. Those are your 2 big ones. This is also one of those medications that you want to make sure, yeah, doxy is great. This is one of those medications that you want to make sure that your patients know that there is a problem with phototoxicity. You can get sunburned very easily. Doxycycline in your body will actually get destroyed by sunlight. And it creates free radicals when that happens. So it can make you rather sick. One of the side effects is something called black hairy tongue. It is not actual hair. It looks disgusting. It also tastes disgusting. You get like a very metallic taste in your mouth. All black hairy tongue is it's dead cells from your tongue are just kind of I'm trying to find the easiest way to put it. They're just kind of like populating there. And it's one of those things that when you stop taking the medication, it goes away rather shortly. But again, it's not actual hair. It's just like this dark area of dead cells that pops up on the tongue. It has a very very strong metallic taste. And the only other note that I mentioned is because you'll see some antibiotics say you can't take this with dairy. This is one of those medications. So doxycycline is a chelator for multivalent cations, and what that means is if it's calcium, magnesium, anything on that side of the periodic table that has 2 or more electron spaces. So it'll be like those +2s, +3s. If you take this medication while you're eating something, or take medications that have those in there, so for example, Tums. Tums has a whole bunch of calcium in it. If you're taking anything like that, it will actually bind to doxycycline and make it ineffective. So when you say chelation, what chelation is, chelation just means it's a binder to something specific. So same thing with like lead, aluminum, heavy metal toxicity. All chelation means is you're binding to a substance and removing it. That happens with doxycycline. So if you're taking doxy with something that's got a high amount of calcium in it, high amount of magnesium in it, it'll actually interfere with the doxy and cause it to be excreted, and it actually won't have any effect. So that's how tetracyclines work. Again, protein synthesis basically just stops bacteria, ribosomes from being able to print out proteins effectively, which inhibits their ability to repair themselves, inhibits their ability to metabolize things in their environment, which basically they go hungry and starve to death, and it inhibits their ability to reproduce because you need proteins in order to reproduce another cell. Like, so for example, if a protein wants to produce a protein, if a bacteria wants to reproduce, it has to double its amount of protein to make 2 different cells. If it can't do that, can't reproduce, and the cell eventually just dies off. I think that's the end of my show. This was, I said, this is a very abridged version of it. There's much longer ones that you sit through for class. I actually took, I think, about 3 weeks and kind of stuck them together here and removed all the stuff that makes the stuff really, really complicated. I'll probably in the future make another stream that has to do with the way that these work. But in order to do that, we have to get into some microbiome, specifically like cocci and rods and how different bacteria live and exist. So I can't just go into it saying, hey, this is how we treat an ear infection without talking about, for example, the bacteria that cause ear infections or the viruses that cause ear infections. I actually haven't even talked about antiviral medications, antifungal medications. There's a whole lot of things out there that I can talk about. But and if I want to talk about how these work specifically on different organisms, I have to talk about the organisms. But yeah, so that's the end of this, I think. Yep, that's the end of that. Second, here. I apologize because we're about to get a big thing on my screen. Yep, there it is. Get rid of this. Nope, I lied. Get rid of this. Yep. There we go. All right. So, do we have any questions on anything at all? Feel free to answer or send something in the chat real quick. I'm gonna be here for just a little bit because I want to at least make sure I reach the hour. We finished at about, we're at 53 minutes now. Hop into Did I post these online? Yeah, I'm actually going to be putting this into my I'm putting this into my, yeah, there we go. Okay. Ooh, trying to get to that screen is a pain in the butt. I'm going to put this into my YouTube. So when this is done, I'll have a, this will stay up as a stream for, I think, like a week. Oh, I didn't change the title of this. So it says enter the stream next. It'll be up there for about a week, but I'm going to download this and stick it onto my YouTube. So, by the way, if anybody's interested, you can go to my Patreon, subscribe over there. The Patreon is completely free. The basic subscription is free. All the content that's going to be on there is free for anybody. There is a paid subscriber option. You can, I think it starts at like $5 and goes up from there. And all that does is it gives me the ability to do this. It's just a supporter thing. You can support my attempts at making education accessible, especially medical and healthcare education, make it accessible to other people. And while I'm also med school, because we're not allowed to work while you're in med school, not that you really even can, because you're there for like 8 a.m. to 5 p.m. most days of the week, from July to December, and then from January to May, June. So you're not really able to work. No. So a lot of med schools contract you and make sure that you sign the contract that you will not work while you're in medical school. There are other medical schools which tell you that you can work, but they are going to very strongly, very, very strongly advise you not to work. If you do work and your grades suffer, you have to go into an academic plan with them or an academic improvement plan. And one of those parts of the improvement plan is that you're going to quit the job that you have, and also not participate in any clubs that you're participating in. It sucks. It makes med school very, very, very unaffordable in a lot of ways. The financial aid that is made available to you does not cover a whole lot of everything. Um, so yeah, when you go into med school, you want to make sure that you have um, just enough of your financial stuff aside to assist with the financial aid that you're going to get, which is going to be very meager. Yeah, as I said, like not every school prohibits you, but a lot do, and the ones that don't will very strongly lean on you and be like, yeah, if you start screwing up in your semester, you're gonna have to you're gonna have to figure it out because we don't want you to work at the same time. Any other questions at all? Yeah, you have a good night too. I'm gonna hang out for a few more minutes because I just want to make sure I reach my 60-minute mark. Yeah, absolutely. As I said, like any questions are welcome. You can even message me on Twitter. Uh, so Twitter, it doesn't allow me to get messages unless we are both following each other. But you can find one of my posts and just comment on it. I pretty much reply to most things on there, with the exception of trolls and stuff that try to mess up my feed. Um, but you can get me on um, Twitter, Blue Sky, YouTube, um, Patreon. I'll probably put a poll out in terms of what people want me to do next for my next pharmacology. I'm probably leaning more towards like adrenergic medications, so things like epinephrine, norepinephrine, um, albuterol, ipratropium's not really an adrenergic; it's more muscarinic. Um, yeah, go ahead, follow me on Blue Sky. I always feel super bad because I always forget that Blue Sky exists. And Mastodon, screw it. Like I've just given up on posting there because I just forget about it. And also, it's kind of like talking in the woods by yourself because no one ever responds to you on Mastodon. Um, but I keep forgetting about Blue Sky, and I jump in every once in a while, and I will leave like I'll leave notes there, and I occasionally hop on, but it's so hard because I have like I don't have a Facebook for this, and I probably just won't ever have a Facebook for this because I hate Facebook. I only have a personal Facebook, but yeah, I'm probably going to be putting up a poll on my Patreon account probably within the next day or so. I think the next thing that I wanted to do, I had a lot of requests for EKGs, so I think I'm probably going to talk about EKGs next. Um, but I think I'm also going to start just opening up to, as I think I have enough followers at this point where I can start opening up polls because the first time I had a poll, it was like I had 3 followers, so like it didn't make any sense to follow what was going on in the poll just because there was just I had a like 3 or 4 people responding to the poll, and I was like, okay, well, we'll just wait until I get a few more followers on there. But so so the idea I think is I'm going to put it out there and say see what people want to do and what they would like to see next. So yeah, also thank you for the follow. I have this I have the chatbot widget up, but I think I just didn't activate it for today's. Yeah, I think I just didn't activate it, and I can see my friend has joined me in the background. Uh, it's a Shiba. All right, go back. Yeah, someone says hi to you. Oh, you wanna come say hi? No, you just want to leave. You've had enough of my BS. All right. All right, we have officially hit an hour. So if anybody doesn't have any questions, I will be ending the feed. Again, if you have any questions, you can hit me up here, Patreon, YouTube, Twitter, Blue Sky. All right, have a good weekend. And if I don't see you, have a good break for those of you who are on break.